Good morning, everyone, and welcome to New York. My name is Prakash Krishnan, and I welcome you to this month's rendition of CCC Live Cases and Peripheral Interventions Live from Mount Sinai Hospital, New York. Due to the ongoing COVID-19 crisis and the pandemic that's going on, we missed our live case transmission last month, rightfully so. And so this month, we sat down and thought about how we can go ahead and really continue to contribute to the vascular education of all our audience. So it really gives me great pleasure to announce that we've been able to put together a panel of experts from our very own Mount Sinai faculty, our close friends, our colleagues who have been in the front lines fighting this COVID-19 pandemic. And what I think a lot of the emails that we received from all of you over the last month was a lot of questions, and I think it was very difficult for myself, Dr. Kapoor, and others to answer certain questions because it was really outside our experience with this virus, and also there was so much new information being Sitchell Professor of Surgery here at Mount Sinai. The Dr. Robert Lookstein, who's the Executive Vice Chairman of Diagnostic, Molecular, and Interventional Radiology, and has been part of our team for now many years. Then Dr. Vishal Kapoor, who's the Director of Endovascular Services at Mount Sinai St. Luke's and is also an Assistant Professor of Medicine. Then we have Dr. Sardar Farhan, who's new to our team, who's an assistant professor who just joined us this year as our faculty. And then we have Dr. Jay Mako, who's the system vice chairman of neurosurgery and professor of neurosurgery. And last but not least, we have our very own Dr. Jeff Olin, who's the director of vascular medicine and the vascular diagnostic laboratory for the system, and was a professor of medicine here at Mount Sinai. So on behalf of all of us and the audience, I really want to thank all of you. I know all of you have so many things going on that you took the time to be able to really contribute. And I've shared a lot of the email questions to our faculty. So I'm just going to get started. Before I get started, any comments from all of you, or should we just jump right into it?
Thanks for organizing. I think this is a great idea.
Great. So we broke it down into three different parts, and I just want to start. And what the first question is really a question to all of you, and I think it's really in the mind of everybody who's treating vascular disease. And the question was asked by a cardiologist who's actually in the community in New Jersey, and what he wrote was, what is the role of endothelial dysfunction in the vascular complications associated with COVID-19 patients? And I open that up because I know it's a very controversial topic. First of all, is there or is there not endothelial dysfunction? And is that the main reason that we're having so many vascular issues with these patients? So I'm just going to open it up to, I'll start with Jeff and your thoughts on that, Jeff.
Yeah, actually, there's a fantastic article in press right now in Lancet Rheumatology by this guy McDougall, who's internationally known in this area, and he's published extensively on this macrophage activation syndrome. And what happens is there's so much inflammation that's occurring. He's predominantly looking in the lungs, but this happens everywhere. So much inflammation is occurring that it causes endothelial damage. The endothelial damage then initiates this whole complex clotting dysregulation that occurs in this. And we can get into the details of that as we go on. But it's a major reason why we see so much thrombosis in these patients.
Now, Jay, Rob, Peter, but to the three of you, is this endothelial dysfunction resulting? And this is a question from an interventional radiologist. Is this thrombosis? Actually, his question is this thrombosis really occurring more in the arterial or the venous bed? And are you seeing a prevalence in one more than the other?
Yeah, well, to speak from a peripheral vascular standpoint, we've seen quite a number of both the venous and arterial acute thrombotic complications. I don't think it's as, for us, and at least initially, it wasn't as unexpected to see the high prevalence of venous complications of thromboembolism, but these acute arterial occlusions with no underlying pathology, I think speak to the processes Dr. Olin was outlining. We certainly have seen a significant number of those.
If I could just comment a minute, there was a recent paper, and we're looking into this too. We've designed a protocol to look into this. There's a paper that suggests that 40% of these people have DVTs. So it's just that we don't look. And when you talk about thrombosis in this, I think you need to talk about the arterial and venous thrombosis that Peter just discussed, and microthrombosis, which is occurring in the lung for sure, probably the brain. We'll have to ask Dr. Mako, but in other organs like the kidney as well, there's a high prevalence of kidney injury in this.
Jeff, could you comment on that? I believe the reference that you're mentioning about 40% refers to a very severely critically ill ICU cohort, not somebody who's walking down the street who might be seropositive, just as an example.
Actually, you're correct on the published study, but there's another study that's currently undergoing review that suggests that you might not have to be that sick, and that the predictors are, like, for example, if you have a Ddimer that's 6 times higher than normal, your mortality rate is very high, and there's a very high likelihood you're going to have a venous thromboembolic event. So yeah, you're right, Rob, but there's a paper that I think will be published soon suggesting that you don't have to be that critically ill.
So, I want to keep moving to certain other questions because I think they're very relevant to our practice before we get into the deeper discussion. And one of the questions is asked by a vascular medicine doctor in Alabama. And the question is, in his practice, he's feeling that how does he triage patients for in-person ambulatory versus telehealth encounters? And he's doing telehealth in his practice. And what he's asking is, when a patient wants to see him, how does he triage the patient? And he's asking our advice in trying to find out what is our mechanism of seeing who should come in and who should not come in. Vishal, you want to take that one?
Yeah, I mean, so my whole goal is try to identify the patients early on. So I'm trying to do telemedicine on as much as possible. And my whole factor is, how is the clinical symptoms change as compared to, let's say, 2 weeks ago or 3 weeks ago, or the onset of symptoms. If there's something like one of my critically ill limb ischemia patients who has persistent pain with no worsening, I just follow them clinically and see them on telehealth so often, 2 weeks, 4 weeks, depending on how it is. But let's say a patient gets in touch with you and say, like, okay, I was fine like 4 days ago, and suddenly last 2 or 3 days, my symptoms have suddenly come up or got worsened. And that's probably one of these alarming signs which I would want to interrogate. And like Rob and Dr. Olin talked about TBT and atherosclerosis and COVID-associated disease, I would like to triage them to see if they have any associated COVID symptoms related to it or not, and then probably take it from there. If there's some COVID symptoms affiliated and the symptoms are acute on telehealth, preferably if you can identify it, then they probably need further evaluation and recommendation in form of anticoagulation needed bit. But if it's mainly pain which could be managed remotely and they're at low risk with low symptoms, then I just manage them medically through telehealth and then do a close follow-up, let's say 1 week follow-up or 2 weeks follow-up.
Is there any difference with Jeff, Peter, Jay, or Rob?
Yeah, I mean, I would echo that. I think for us, we also have patients with significant wounds, and we are able to follow those to a degree with telehealth and having the patients send us pictures of the wounds, and we monitor their temperature. But it is challenging to manage to perform wound management through this sort of telehealth mechanism.
Okay. There's a question here for I guess regarding diagnostic testing, and I wanted to actually ask one before that. As a group in Mount Sinai and in different specialties within the hospital, are you requiring COVID PCR testing for all in-person encounters? And I don't mean in procedure, before they come to your clinic. How do you triage the patients if you do need to see them? And then is there a difference between a clinic visit and a procedural visit?
So,
Rob, do you want to?
yeah, I'll take a stab at that. Right now, I believe the health system's policy is that any patient who's coming in for a procedure or surgery undergoes pre-procedure PCR testing at a maximum of 48 hours before the scheduled surgery or procedure. And we have a dedicated space at multiple campuses where a patient can hopefully conveniently come in and get swabbed to have the results back before they arrive. Our current turnaround time in the institution, PCR testing, is approximately 12 hours, and sometimes it's as fast as 4 hours. So there's really no reason, based on the schedule I just described, that a patient shouldn't have that result back. We actually have had unexpected positive results, and we've contacted those patients and asked them to reschedule unless their symptoms are so urgent or emergent that they have to come in which case we make special arrangements for a direct admission. In terms of the ambulatory office visit, there's no mandate right now currently. Where our office is, and I believe this is replicated across the faculty practice, we're calling everybody before they arrive for a face-to-face encounter and going through a very detailed screening list, including previous history of infection, exposure, whether they're currently febrile. And then increasingly across the healthcare system, patients are being screened as they arrive at the front door for the presence of a fever before they walk in. So that's how we're screening patients currently. That's obviously a process that's an evolution, but we feel that that is the best mechanism at present to keep everybody safe.
Excellent. Thank you for that in detailed answer. Jeff, this is a question directed directly at you from Texas. As a vascular medicine professional who is doing screening tests or doing diagnostic tests, which diagnostic test are you using as your primary test for arterial disease, for venous disease, and second, how do you protect your staff during the testing time during this COVID-19 pandemic?
Okay, so I'll take the last part of that first. When it became apparent what was happening here, we sent out a memo that all elective vascular laboratory tests were going to be canceled until further notice. But there are certain tests urgent tests that we would do no matter what. For example, rule out pseudoaneurysm, rule out deep vein thrombosis, symptomatic carotid disease, acute limb ischemia. We would do those patients, and we have, and we've been doing we normally do 60 studies a day. We've been doing about 7 to 8 a day. Every patient is treated like they're COVID positive. So the technologists use all the PPEs that are necessary, and several of our techs have already had COVID and have antibodies present. So everybody's treated as COVID positive. If we know for sure that someone is COVID positive, we have designated one room for that each day, and at the end of the day, that room gets terminally cleaned. So that's how we protect everyone.
Wow.
Which test do we get? I mean, it's the same as what we would normally get in the non-COVID era. Each vascular specialist has their own protocol of what they like, but basically ankle brachial indices. We're not doing treadmill exercise testing because of the risk of increased respiratory droplets and things like that. and then duplex ultrasound of really anything that we would normally do in the pre-COVID era.
Okay. Thank you. There's a question that I need to answer from the audience saying that how come no one else is wearing a mask? I do want to say that we are following protocol, and I should have mentioned this in the beginning. It slipped my mind. All the faculty is in their private offices without anyone next to them. I'm wearing a mask because obviously our AV team is in front of me, so that's the reason why nobody else is wearing a mask. Around the hospital, we're very, very strict. Everybody you see here will be walking around with a mask, or if there's any sort of public interaction, they will have their mask on. Now we're going to move on to the next because I wanted to stay on time, and there's been a lot of questions about stroke. So Jay, I'm going to ask some of the questions that have been emailed for us. We have 4 questions already here that we may actually just have to ask you to answer as well, and the rest of them. So first, this is directly to Dr. Mako and Dr. Ferris. This was directed to. There's been a lot of there's a lot of news about the increase in strokes in people without risk factors. Particularly, Jay, I think they're talking about the news that came out of Sinai, as well as the congratulations, recently published New England Journal article. Can you comment on this? Is this more prevalent? Specifically, is this more prevalent than we know, or do we have any idea that is this going to be something that is a new syndrome in patients with mild COVID symptoms? Jay?
Yes. The short answer is yes. The paper that just was published that people can see in New England Journal, it's an urgent communication, only highlights 5 patients, but it's sort of an alert and a wake-up call for all of us, because we had 5 patients in their 30s and 40s presenting with large vessel stroke that were all positive for COVID-19, and half of them they had no other symptoms. The others were at home and just had mild symptoms, a cough and things like that. So as Dr. Olin was saying before, these things can happen early in the disease process. And so after we sort of had this incredible experience, and it's important to note, this happened during the COVID surge across New York City. So this is when the disease was at its highest in terms of being endemic in the population. I certainly don't think this is going to be happening to everyone everywhere, but it's an insight, it's a clue into the pathology and the pathophysiology that's happening. We've since looked at a broader spectrum of patients, and we saw a doubling of the number of strokes presenting to the hospital over that time period. Again, these are not hospitalized patients. This is different than the Wuhan report, where they saw high rates of stroke in chronically ill patients that have been in the ICU. These are patients showing up with stroke. Over half of them were COVID positive. And what was really striking was the COVID positive population was very different than the normal typical stroke population. They were 15 years younger. They were more likely to be men, which we know COVID, it appears, affects men worse than women. They were less likely to have AFib, less likely to have heart failure. There were a lot of things there. So to me, this was a pretty dramatic road sign saying this disease is affecting the blood vessels, it's prothrombotic, and it's causing this. And sure enough, talking to Peter, talking to Rob, talking to our pulmonology colleagues and UPK, it's clear that we're all seeing these kind of thrombotic events broadly.
So Jake, can you go over your presentation now as well to get started?
It's got to go down on record of only 5 patients and published in New England Journal. That's nice. So that was, and I think we have more authors than patients, but it was more about raising awareness and getting people to understand that this is happening. And I know there's been also a discussion across the country and world about decreased presentation for heart attacks, decreased presentation for strokes in lots of communities, likely being driven by fear. We're doing an analysis right now, but even just within this cohort, if you look at the table, there were very delayed presentations. So even though people can have pretty profound neurologic deficits, they're afraid to come to the hospital because there's been so much news about the downside of going to a hospital. And so this is just, we then did an analysis of all of the large vessel strokes that happened from the moment the surge occurred and New York City closed down and closed the schools for the next 3 weeks. And we saw a doubling of the normal number of large vessel strokes. We looked at a couple different time periods as comparison. We typically see about 20 to 22, and we saw 45. And the population that were COVID positive clearly were different. They were 15 years younger. These are all significant variables. Obviously, this is all exploratory, but statistically, the confidence intervals excluded 1 or p-values were less than 0.05 for them being younger, for them being more likely to be male, for them being less likely to be white, also consistent with the current COVID crisis in New York City, less likely to have AFib, less likely to have heart failure. So to me, this is a pretty strong indicator, and that this disease is prothrombotic and is certainly associated with stroke. And as all of you have been saying, is associated with lots of things. And so, this was, Dr. Rowland, I think, was talking about some papers coming out in Lancet and other ones. This one caught my eye. This was just published last week, but it shows that the virus can certainly directly affect endothelial cells in vitro. We all know the ACE2 receptor has anti-inflammatory effects and has been implicated in plaque formation and the rest of the things. So, this is all speculation, but perhaps there is some direct endothelial injury occurring here that's leading to this profound global vascular disorder that we're all seeing in our respective fields. And that was all I wanted to share.
So a question just came in, I guess, when you're talking, this may be to the entire panel. Does this change the management of the asymptomatic patient with COVID? Meaning, is there enough data to suggest now with what Dr. Olins and Dr. Luchstein were talking about with the increased risk of venous thrombosis, what Dr. Ferry's talked about with some increased risk of arterial thrombosis, and now with the increase of strokes? Is there an indication, or can we suggest that we should monitor these patients closely, either with blood work or with antiplatelet or antithrombotic therapy?
I think there's enough information. First of all these studies that you're seeing, half of them are not even correct. They're just small observational studies. And I can tell you, at the Journal of the American College of Cardiology, our submission rate has doubled from 300 a month to 600 a month. Actually, 300 a week to 600 a week. And half of them are just junk. But I think there is enough evidence that patients who are anticoagulated, especially hospitalized patients who are not yet in the ICU, have a lower mortality rate than patients who aren't. The question is whether or not patients who are at home should be anticoagulated.
That's the question, yeah.
And I personally believe they should. Do you use prevention doses or full doses? I don't think there's enough evidence yet that full doses should be used. But there's definitely a lower mortality in people on anticoagulation overall.
So Jay and Peter, just one. I'm sorry to interrupt, Michelle and Rob. Since there's some implication on platelet-rich, thrombus that's occurring, should it be again, we're talking about the home patient because they want to know about patients who are at home with mild symptoms. Should it just be an aspirin or should it be a NOAC? Is the question that I just got.
I don't know that we have any data to guide us with respect to whether anticoagulation or antiplatelet agents should be administered to these very mildly symptomatic or asymptomatic patients. And there obviously are potential complications of anticoagulation itself. So, my bias would be to say to add an antiplatelet agent, either aspirin or Plavix potentially, but and maybe a prophylactic dose of a novel oral anticoagulant. But I don't think I would recommend full anticoagulation for outpatients.
Jay, anything?
Yeah, I mean, we all know that there's also potential substantial downsides to anticoagulation of any sort. And so I really think, this is going to sound like a cop-out, but I really believe it. I think this has to be a a conversation between a patient and their doctor, because every patient has their own risk profile. In a young, otherwise completely healthy person, they start taking some aspirin as a hedge. I mean, it's a nearly minimal downside. But in an older patient that might have a history of having a subdural hygroma or something, and you start giving them medications. So I'd be very wary of any kind of blanket statement to that effect. But I do believe it should be something that physicians should consider in the context of caring for their patients.
Rob, any comments?
So I would say that one thing that's really critical is that on the inpatient side, I think there should be a recognition that these patients are at extremely high risk for, certainly, obviously, arterial thromboembolic events. And, Jay's presentation is extremely enlightening and very concerning, obviously, for how it affects, seemingly young patients. But probably more frequently on the venous side. Jeff touched upon this before. I don't think we understand the true extent. We're starting to get some data coming through about how extensive venous thromboembolism is. And I think the health system has been grappling with this. Initially, there was a protocol to give patients prophylactic doses of anticoagulation. And I think we're recognizing more and more that there's a subset that has deep vein thrombosis, that has pulmonary embolism, and this is going on in a climate or in a culture where people are, I think, pulling back on performing diagnostic tests. People are concerned about moving patients around the hospital to get CT scans, for example, a CT pulmonary angiogram. There might not be a liberal threshold to perform lower extremity duplexes on inpatients, especially critically ill patients. Resources might be scared. But however, we're finding out that these venous thromboembolic cases are much more frequently seen than was previously appreciated. And I think that we all need to work in our local communities, our local hospitals to sort of change that trend and create a culture where we are comfortable performing diagnostic testing so that the patients who do need, certainly by the guidelines, therapeutic anticoagulation are diagnosed in a timely manner.
That's a great point.
I mean, there is, if I may interrupt as well, there is recently went online yesterday, actually, or 2 days before, a comment in the Lancet Hematology correlating the risk of bleeding and the risk of in these patients with COVID who are at high thromboembolic risk. And they found that those two criteria actually correlate. So those patients who have high risk of thromboembolism are also in 40% those patients who will have a high risk of bleeding. So in this kind of population where the patients are vulnerable, old, and probably also on mechanical ventilation, a judgment regarding balancing the risk of bleeding and ischemia should be actually also performed. Are there any recommendations regarding using a certain risk score like the Padua score, or should we use coronary scores like the DAPT score or Paris risk score, something like this?
Any comments, Vishal? I mean, with these scores and what Sardar was just saying. And Dr. Mako, I believe, just froze. He just texted me. Can we work on getting him back? Because there's one question for him.
Yeah, I think, there has been data suggestive of the Padua score or the Paris risk score of trying to assess whether to use one versus the other. But the COVID situation is, I guess, a totally different syndrome right now. So like Dr. Olin and Dr. Luxine are talking about, there is no clear-cut guidelines to say who gets a full anticoagulation, who gets a preventive anticoagulation, of course, based on a D-dimer and the critical situation, but on a day-to-day basis. So I don't know how we can apply these scores so effectively on this subset of group of patients. But as of now, based on our policy and our rotation in the ICU and the in-hospital admission patients, most of them who are critically ill, especially when their D-dimer is high, we are giving them full dose anticoagulation as compared to giving just empiric prophylactic doses of low molecular weight heparin or heparin drip itself, depending on how the situation is.
So there is data at Mount Sinai. I don't have access to all of the data, but I've heard some of it. that when they look at the overall bleeding complication rate, forgetting about the extremely critically ill patients in the ICU or patients on ECMO or things like that, the bleeding complication rate is not all that high. Jay, how many intracranial hemorrhages have you seen related to this? My understanding, they're relatively few.
Oh,
I'm sorry, I was muted. I had a little technical. We have seen, I would say over the last 3 weeks, maybe 3 or 4. But I want to clarify that the hemorrhages that we're seeing are patients that have been put on anticoagulation, that have been in-house for a prolonged period of time with severe disease, and it looks like it's hemorrhagic transformation of old strokes that have occurred, subacute strokes that occurred 5 days or 7 days ago. So I am not convinced, and I've not seen that this disease is causing hemorrhagic disease in the brain independently. I think the hemorrhages we're seeing are patients that had strokes from the disease and are then being put on anticoagulation. That said, even if we just took the Wuhan number of 6% and you apply that to our hundreds of ICU patients that have been anticoagulated over the last few weeks, and I've seen, I think, something like 4. They've all come through me for the last 2 weeks, 3 or 4 at most. So the rate's pretty low.
Yeah, that's my understanding.
Well, that's great, Jay, because the question I had was about that, whether you've seen a lot of intracranial hemorrhages, because it was from an ICU doc who's asking that. So I'm glad you addressed that. So I want to move on for the sake of time, because we're about 4 minutes behind to the next topic, which is PAD, CLI, and ALI. And the first question is for all of you, really, who treat this disease, is have you seen an incidence of increasing in patients with CLI since the COVID outbreak, with critical limb ischemia / acute limb ischemia? So Peter, do you want to take that one? Have you seen an increase in presentation through the ER?
Yeah, there's clearly an increase in presentation for, again, over what we would baseline see in the same interval. We've seen an increase in the presentation of acute ischemic events, and again, frequently not in patients with underlying symptomatic peripheral arterial disease or even any peripheral arterial disease. So it does seem to be a primary thrombotic event that occurs. But yeah, we've seen a significant number of those patients.
Rob, how about you and Vishal?
I haven't seen an uptick in CLI. I think it's more or less flat from, I think, historical perspectives. I think ALI is definitely going up, and that creates unique problems in terms of how to manage them. Peter can comment on this a little bit better than I can, but surgical resources are not widely available. Lab time is not widely available, and we're trying to be very cognizant about exposure of physicians and staff. And so we're all trying to grapple with how to treat the patients in a timely manner that is efficient. Ideally, a single therapy that is hopefully very, very rapid. It's almost like triage, for lack of a better term. So I think we're all grappling with this. It's particularly challenging, but at least from my perspective, there's definitely been an uptick in acute limb ischemia presentations.
So this leads to the next question, I think, which is very important for Peter. This is from a general surgery group down south who talk about decision making in patients with CLI, ALI, people that you would normally try with a surgical approach. Has your thinking changed regarding general anesthesia in these COVID positive patients? And are you leaning more towards endovascular revascularization rather than surgical revascularization in these patients because of the fact of the increased risk of exposure to your colleagues in the hospital, as well as a worse outcome of patients if they're intubated or need general anesthesia? Peter?
Yeah, I think those are really excellent questions that highlight some of the decision making. And we've kind of gone through this process. That was sort of our initial approach. What we found, and again, this is strictly anecdotally, is that at least for the acute limb ischemia, the endovascular approaches did not seem to be as efficacious, certainly not as rapidly. And we've started to lean more toward open surgical thrombectomy and then any associated endovascular procedure, with when we perform those thrombectomies with a radiographic guidance. You can still do those types of procedures with either regional or local anesthetic. I think the general anesthesia considerations are also very legitimate. When we treat patients surgically that require general anesthesia, the patient is actually intubated with just the anesthesiology attending in the room, no one else. And then the staff will come in and prep and what have you, and initiate the case, again, to try to minimize exposure to the operators. Dr. Lookstein's done a great job down in interventional radiology and setting up the dedicated room for treating patients who have COVID. And I think that's been highly successful also in protecting the operators. So I think, and our patients that have required bypass and general anesthesia actually have been able to be extubated if they didn't have underlying sort of pulmonary manifestations of COVID. So, so our initial kind of bias was to try to minimize general anesthesia, and I think we still do that. But as far as surgical versus endovascular revascularization, I think for at least these acute presentations, we're treating more of them surgically than we had been at the outset of this.
Got it. Question to both Jay and Peter. High-grade asymptomatic carotid stenosis during the COVID era. Are you approaching this surgically or with carotid stenting or medically managing these patients? And how do you discuss this with the patient? This is a COVID negative patient who's got a high-grade asymptomatic carotid artery stenosis. The question is, how do you manage them? And even for Jeff, in terms of surveying these patients during this time. Go ahead, and Jay?
On the neurologic side, we've been waiting. We're medically managing these patients. We've had a number of symptomatic disease patients that we've taken care of, but for asymptomatic disease, as we all know, there's already a real discussion and a question of the appropriateness of treatment, which I'm a person who believes sometimes it is appropriate, but in this circumstance and in this environment, I don't see it being reasonable, at least in the short term, while we're working through the more drastic parts of this disease and figuring it out.
Yeah, I would just echo that. It's particularly during the surge, we deferred all non-urgent surgical procedures, vascular surgical procedures. So for asymptomatic high-grade carotid disease, we've deferred intervention for the time being. Although as we sort of resume our practice, we will at some point start to treat those patients again. But it's been about 6 weeks, I think, since we've treated asymptomatic carotid disease.
Great. One question directed to both Rob and Vishal specifically. Do you have a designated, as Dr. Olin has for his ultrasound patients, do you have a designated lab for COVID positive patients for endovascular therapy for CLI/ALI? So Vishal, why don't you take that?
So yeah, so at Mount Sinai St. Luke's, they have a dedicated lab and primarily we try to avoid routine ultrasounds if they have to, unless it's really indicated. But if there's a COVID positive patient, then instead of doing portable ultrasounds, they actually have a dedicated area in the echo lab which has proper COVID precautions, PPEs, and a very limited staff, only one technician and nothing else there to take care of patients and have minimal exposure as much as possible when it needs and arises to be. The outpatient clinics of mine, we have essentially stopped those regular testing because it's more of an outpatient setup, so it's not an emergency. So that's where we stand on the screening part from the ultrasound perspective.
So those that are on the webinar that don't know, Jay and Peter and I work in the same lab. So it's been a true collaboration through this crisis, and I'm very appreciative to both of them for their partnership. I think initially before the surge, we were trying to be relatively modest, and so we dedicated a single room that was going to be specified for all COVID cases, and we left the rest of the fixed rooms to be used for non-COVID work. Once it became clear that the hospital was going to surge to the extent that it was, where almost every bed in the hospital was COVID positive, we actually shifted the entire lab for about 2 weeks so that every room could be used as a COVID positive lab. We had to downscale, reconfigure all the rooms, in-service all the staff about how to properly prep the patients in the rooms, remove the unnecessary equipment, including anesthesia equipment. That lasted for about 2 weeks, and now we've defaulted back to the original plan, which was having a single dedicated room that we all share for COVID positive cases, and the remaining rooms are still being used for both outpatient, emergent, and urgent cases that are not COVID positive, as well as inpatients that are COVID negative, as we're starting to see more of those patients coming through either through the emergency room or direct admits.
Got it. There's actually a very good question here that just came through on the website regarding COVID toe. There's been a presentation of thromboembolic patients who are asymptomatic. Is this a reflection of the active inflammation that's ongoing within their endothelium? And should these patients be considered for therapeutic anticoagulation? And this is directed at all of you. There's no specific person. Jeff, why don't you?
This is unbelievable. There's been a number of reports on this. It looks just like pernio. I mean, these lesions, if you didn't know that COVID was going on, you would think this is a cold-induced vasospastic disease like pernio. I don't really know why this occurs. I don't know what the treatment is, but people are noting it more and more.
Anything? I mean, but Jeff, would you recommend anything on this? I mean, is this considered an embolic issue, or we just don't know? Don't know enough at this stage.
I don't think it's embolic. I've seen a number of these via emails and people sending me pictures, but I don't know what it is. I mean, I haven't seen any histology on it, so
Okay.
none of the reports have really done that. Peter,
So, Peter,
have you seen any of this?
Yeah, I've seen a couple of patients that have presented with this, and one young male patient actually started in his fingers, and then was evidence in his toes. And you don't really see other sort of distal terminal vascular beds being affected. So my inclination is the same as yours, Jeff. It does not look like it's really microembolic in nature. At least I've not seen anything that suggests that it is. It may be something that's more vasospastic in nature, and I can't say that I understand it to any degree beyond that. But I hadn't started anticoagulation for those patients, and I don't know if we should or should not. But to this point, I have not. I
haven't either.
So this question is actually a little, we're backtracking, but it's from a vascular surgeon within our own system who's asking all of you, with the onset of telehealth for evaluation of vascular patients, do you plan to continue doing this in the future in order to be able to either see more patients or be more efficient within your practice?
So it's not clear to me that telehealth is more efficient. That's the first thing. Let me just put that out there. I hope it becomes more efficient, but at least I haven't gotten there yet. Maybe other people have. I think that telehealth really makes sense for a number of follow-ups. I still have real concerns about doing a new patient intake over telehealth, especially for somebody with critical limb ischemia, deep vein thrombosis, a number of relatively severe diagnoses. To do that over telehealth, I'm still very reluctant. However, I think that for increasingly patients where we're performing 6-month follow-up, 12-month follow-up, maybe even 18-month follow-up after a therapeutic intervention, I think that's probably where this is all going to end up, and I'm becoming increasingly comfortable with that paradigm.
Okay, great. Just a question now. I think now we're going to have to move on to venous disease as more questions come in. But I think with our last 10 to say 15 minutes, we need to concentrate a little bit on this. And this one is specifically towards Rob and Jeff. Both of you speak about an increase in venous thrombosis. Has there been an increased incidence of venous thromboembolism presenting to Mount Sinai with COVID infection during this pandemic?
So we actually looked at this very recently, and we're putting this in preparation for submission. But in the last 30 days during the surge, we saw a 60% increase of acute pulmonary embolism presenting to our emergency department across the healthcare system as compared to the same time period last year. Not as dramatic an increase as Jay saw for stroke, but the numbers are obviously much higher. Where you're seeing dozens of pulmonary embolisms come in every single week. So it's definitely more conspicuous. Obviously, we're trying to get the demographics together to see if it's a similar cohort or a different cohort. But without question, the Mount Sinai Health System is seeing more acute PE than we did historically.
So as follow-up, there's a second question that was just sent in now regarding the inpatient setting. This is to, I guess, vascular surgery specifically, and as well as you, Rob, because you're leading the PE workforce here. It says specifically, in these patients who are intubated, has your approach for treatment with PE, who have pulmonary embolism, has your approach changed? Are you lysing these patients, or are you also doing mechanical thrombectomy of these patients and thrombolytics?
So we've not been liberally performing mechanical thrombectomy. I think, as a matter of fact, the shift has turned in the opposite direction, where there's been a very low threshold to treat the patients medically, and the preferred intervention currently is a systemic administration of a fibrinolytic agent. And obviously that decision is a very significant departure from what we've been accustomed to, but it's taking into consideration that the patients are obviously critically ill. There's concerns about moving the patients across the hospital. There's concerns about the stability of being able to ventilate the patients appropriately as they're moving to different locations within the institution. And then just conversely, I alluded to this earlier, we don't have the surgical resources as widely as available as we did before the surge. So in order to do an open embolectomy, it's just not easy to mobilize that whole team in contrast to where we were 60 days ago. So I think right now we're comfortable being a little bit more liberal with fibrinolytic agents. I think we're reassessing that probably every few weeks, but that's where the default has been.
Okay, if I could comment on this, there are two issues here. One is pulmonary embolism, the way we understand it. The other is microthrombosis in the pulmonary circulation. And in these critically ill patients whose PCO2 goes up, there's been initially 6 or 7 patients who received TPA and later tenecteplase, who you administered a bolus and then continued a very low dose strip over 24 hours, and it seemed like they reversed completely. They became much better. Their PCO2 came down. They did well for about 3 or 4 days, and then they crashed again. So it appears that there's a lot of microthrombosis, but the damage to the lung is so severe that it doesn't really solve the problem. And there's a paper that has been submitted regarding this.
That's a great point, Jeff. There's one question here with Dr. Mako, just on the same situation that I asked Dr. Lookstein and Dr. Ferries and Dr. Olin. with acute stroke in the COVID positive patient, are you now in the COVID positive patient? Are you now using thrombolytics, or is endovascular interventional therapy still ongoing in your practice? Forgive me, it's a lot of blurriness.
No problem. Our treatment paradigm hasn't changed. Our process in terms of having dedicated COVID unit, keeping the equipment out of the room and having a separate individual who passes it in, all those sorts of things. But no, we're still performing thrombectomy. We're still performing a fair amount of it. We treat all strokes as PUI, patients under investigation, because we have about a 60% COVID positivity for the strokes that are presenting. That is, from all the data that we have at hand so far, a higher percentage than in the public, again, which shows a correlation to me between the disease and the virus. So we treat every patient with full PPE as if it was a COVID positive patient. But we're still performing thrombectomy in this patient population. The impact of the treatment is too profound relative to the medical therapy, with a 2 to 3 fold a number needed to treat of 2 to 3. So we're still doing that therapy.
Thank you, Jay. To Jeff, this is actually to Jeff, Rob, and Peter. Given that biomarkers are abnormal in patients with COVID infection in the hospital, such as D-dimers, what do you recommend as a biomarker for looking for pulmonary embolism in these particular patients?
Well, I don't know that there's a good, troponin and BNP is going to go up in anybody. Troponin is going to go up in critically ill people with COVID anyway, as is D-dimer. So I don't know that they're particularly good for diagnostic purposes, but they're good for prognostic purposes. For example, the level of D-dimer is highly predictive of mortality. So I don't know, Peter or Rob, if you have any other experience regarding that.
No, I think we're all struggling with what the biomarkers should be or could be. I think we're all looking at D-dimer, as Jeff alluded to serve as a catalyst to initiate systemic therapeutic anticoagulation instead of prophylaxis, because of the mortality data that Jeff just referenced. But we're all struggling. Should we use D-dimer? Should we use troponin? Should we use CRP? Again, we're all trying to figure this out and correlate what the biomarkers are presenting and which particular phenotype, whether it's stroke, DVT, acute limb ischemia, et cetera. And I just don't think we have the data yet to allow the biomarkers to be predictive.
Yeah, I would echo those sentiments. I think just as Dr. Olin was alluding to, all these critically ill, particularly the ones with COVID pneumonia, have elevated D-dimers and C-reactive proteins and troponins. And I think it's just an indication of the severity of the disease, not a marker for pulmonary embolism or other specific events.
And IL-6, you should mention, because this interleukin-6 is what has led some people to suggest IL-6 inhibitors in these people. There's no data that does any good, but this is very similar to the thrombosis that occurs in Behçet syndrome.
Yes. So there's a lot of questions. So I'm just going to tell the audience that please continue to send your questions. I will email them to all the doctors that you've requested and request answers, and we'll put them on the website. But last two questions, and this one is specifically for Dr. Ferries, Dr. Mako, and Dr. Olin. Do you think that these large embolus, Dr. Mako especially, you talked about large vessel CVA, with the reports of cardiomyopathy, and maybe Vishal, you can comment on this as well, associated with COVID infections, could these thrombi be originating in the ventricles and then embolizing to the brain? I know these are speculative questions, but these are all physicians.
I think it certainly could be possible. I don't know. I feel completely confident that there's an association. We've also done a radiologic review of all of our stroke emergent imaging that we performed across the system, across multiple boroughs. And there is an association with COVID positivity with large vessel stroke, separate for any neurologic change stroke imaging study. So there's something going on. I think it'd be very interesting if it was coming from the heart. It'd be very interesting. I'd love to hear.
Rob had a case. Rob, what about your bilateral renal artery occlusions?
Yeah, so we had a patient 2 weeks ago that had, unfortunately, a presentation with acute renal failure and was subsequently diagnosed. This was after they were admitted with bilateral either embolus or in situ thrombosis of both renal arteries as well as the celiac artery. And we actually attempted to perform a thrombectomy in an attempt to restore renal function. The thrombectomy was successful, but the renal function is not returned, unfortunately, and we're obviously watching that patient very, very closely. But the systemic manifestations are not just limited to the lower limb or the intracranial circulation. We're seeing broad systemic manifestations across the entire peripheral vasculature.
That patient had AFib. So a lot of these patients do have AFib. So it's important to take that into consideration.
Right.
I think there's
Vishal?
a similar presentation in the cardiac anatomy as well. I mean, we've seen a lot of patients who come in with acute ST elevation and non-ST elevation MI, but they're all non-obstructive disease to begin with. But they do have reduced LV function because of the possible acute inflammatory stage where they have so-called cardiomyopathy, whether it be Takotsubo's or related to inflammation. But trying to find a correlation between cardiomyopathy, LV thrombus, and then possible embolus to all this peripheral system, I guess is right now hard to ascertain. But unless there is an underlying AFib, but there is obviously an increased chance when you present with sudden onset cardiomyopathy that there might be associated embolic event or thromboembolic event going on in addition to the local inflammatory process. So it's a...
So those are great points. Just last question, because I've already sent an email out to everybody, is this is more of a practical question really to everyone. First question this is coming from one of our, I guess one of our colleagues in the medical representative industry. When do you expect Mount Sinai and/or New York to start performing elective procedures? I'll ask Rob to handle that one.
I wish I had a crystal ball about this. I don't think elective is going to happen in the next 2 weeks. I'll put it that way. I think we're all hoping soon afterwards, but we're obviously following the governor's mandate to not perform elective procedures currently. The New York pause is supposed to continue until the third week of May, and I think we're obviously going to look towards our local governmental leaders to direct us. I know we're all keeping in touch with our patients in our office hours and keeping them abreast of the way things are changing, but I still think it's sort of every 2 weeks to every 2 weeks at this point.
Fantastic. Well, I think we're going to stop with the questions there. Dr. Sardar has a nice case that I think will highlight some of the things we talked about, and we'll go ahead and have him present it.
So I'm going to the slides. Oh. So this is a young female patient who presented to our vascular lab. She was referred by a colleague who left our hospital a couple of months ago, and now the patient was redistributed to one of another colleague who was not completely aware of the medical history of the patient, but she was calling regarding ongoing leg pain in the right, more on the left, progressing towards pain in rest. And this is a female patient with a history of CAD, with a recent intervention of the RCA, and she has also PAD diagnosed, and she had a right SFA CTO intervention back in September last year. So the patient has risk factors, typically diabetes, hypertension, she's hyperlipidemic, she's obese, and she's still actively smoking, despite several attempts to quit and undergoing a special cancellation for smoking cessation. She is on dual antiplatelet therapy with aspirin and clopidogrel, given the stents in the coronaries and in the SFA. She has a beta blocker, an ACE inhibitor, metformin, and insulin, and also a nicotine patch. So she she had this presentation with intermittent claudication progressing to resting pain in the last 5 to 7 days. She had no fever, no cough, no shortness of breath, and she had no contact to a COVID positive or suspected patient. So, and we took her to the vascular lab and we performed an ABI. As you can see here, the ABI on the right lower extremity is 0.28. Very severe, and on the left is reduced, but still in an acceptable range for medical therapy. So we performed also a Doppler ultrasound, and as you can see here, that the ostial SFA still shows some flow, and there is also already cessation of flow in the stented segment of the SFA, and there is some limited flow into the tibial arteries. So based on the fact that she is presenting with more acute onset of symptoms and the screening of not being feverish, not having typical symptoms for a COVID infection or any exposure to a COVID positive individuum, we took her to the lab and performed an angiogram, and we found an instant reocclusion, possibly instant restenosis with a thrombosis in the stented segment, and she had 3-vessel tibial runoff, as you can see on the DSA still image. So we tested her before, according to our protocol. We performed a COVID PCR test, which returned back a couple of hours after the intervention positive for COVID. So she is a typical asymptomatic COVID patient presenting to our lab with these symptoms. Although she was diagnosed with COVID, we didn't suspect that COVID is the reason for her thrombotic event, or at least not in the major part, because she has the typical risk factors, and she's still smoking. She's still smoking. So we spoke with our vascular surgeon colleagues, and
Serdar, why don't we stop there? I want to just ask Peter and Rob and Vishal and even Jeff in terms of, what's the appropriate therapy here in this situation? Here's a patient with this clinical presentation, and were they COVID positive? Or
she was positive according to our screening nasopharyngeal swab, but this came back 3 hours after we took her off the table. Yeah.
So this is the situation. Peter, you want to take how should we approach this? I mean, these are obviously some things that people are facing.
Yeah, I think, and again, it's I think a lot of us are facing sort of complicated decision-making scenarios. I would say one is this may be her presenting symptom of COVID. It may be this sort of progressive thrombotic event, because it sounds like progressive claudication that then led to rest pain in a short time frame. So that may have been an acute thrombotic event in the previously intervened on segment. I think it's reasonable to attempt a percutaneous revascularization, but I would look to potentially be treating some underlying thrombotic, thrombus within the occluded segment. So I don't know if an angiojet or some other mechanical thrombectomy component to the revascularization could be utilized percutaneously. If they genuinely have ischemic breast pain and you're concerned about it progressing to tissue loss, then open revascularization, I think, remains an alternative. And we have performed, several bypasses for these progressive rest pain scenarios, what you would have called sort of critical chronic occlusive disease, but I think there may be an acute underlying component. So we have done a number of bypasses in these last several weeks for presentations quite similar to this.
Vishal, Rob, Jeff. First, Jeff, is there, or all of you really, medical therapy? Should we attempt medical therapy? She's COVID positive. You've got, the endovascular outcomes may not be spectacular because of the level of thrombosis, and a surgical bypass might be warranted because and the idea would be, is there a role for us to do medical therapy here?
I don't think so. I think the patient has critical limb ischemia, and it probably should be revascularized. But my question is, this patient has been in a surveillance ultrasound program, I assume, before this occurred, right? And if not,
Yes.
If so, was there any evidence that something was wrong with the stented segment?
Her last ultrasound was in, I think, December, which showed just mild elevation of velocities, but nothing significant for us to treat. And she was asymptomatic at that time. She's been claudicating, and we've been asking her to exercise, but nothing where in surveillance that we felt was something that we need to bring her in and do any sort of intervention. So she was just being followed. And she had actually missed her appointment, Jeff. It was interesting. She had missed her appointment 2 weeks before her presentation because of the COVID crisis. So, Rob, would you do anything different here?
So I just want to make sure I understand the case. So this is a acute presentation of rest pain in somebody who just happens to be COVID positive that you intervened on, or somebody intervened on last fall. Is that
right? Exactly.
Yep. So I would not perform an intervention right now during the acute presentation of the patient being COVID positive as a reflex, unless the patient was in intractable pain. I would put the patient on probably therapeutic anticoagulation. I would see the patient at least a couple times a week, if not almost every day, on telehealth, and make sure the pain's not progressing. And allow the patient to, so for lack of a better word, run their course. What I would be worrisome about would be that the patient would have an intervention, and 2 days later would have a full-blown clinical presentation with pulmonary symptoms, the febrile illness, sepsis, etc., and would be immobilized, admitted to a critical care setting, and would lead to a acute failure of whatever intervention you did, whether it was endovascular or surgery. If the patient recuperates and the local environment, the city hasn't sort of woken up, or people not fully open by that time, and the patient has antibodies, they're testing negative on PCR, I'd probably do an endovascular procedure, not using the same technology that was used here, because it clearly failed in 6 months. And I would use that in discussion with the patient as a temporizing measure to get them probably to the summer or early fall, in the hopes that they could have something more definitive, which would likely end up being a bypass operation, as Peter mentioned.
So Rob, I think these are great points, and I think Vishal, for the sake of time, because it's 9:10, we're going to ask Sardar to see what the team decided, because we did call a multidisciplinary team as always, and what we'll do is we'll just sum up our conference after that.
This was actually, we had an extensive conversation with our colleagues at that time. The COVID pandemic just hit New York really hard, and no ICU beds available. So the option of performing an endovascular approach on the spot right now was not available, because we were worried that thrombectomy alone might not be enough, and we might need to use a TPA, catheter-directed TPA, with the need of an ICU bed, and which was not available. So we discussed with one of our surgical colleagues, based on the fact that she already failed endovascular approach, and she might need a more definitive treatment, and her risk factors, including diabetes, to go for a bypass surgery. So once the COVID test turned out positive, we deferred from surgery as well, because of the risk of transmission of the disease during the elective intubation, and the bad outcome of these patients with having any intervention or surgery done in their active COVID infection phase. So the patient was treated 2 days on the floor with intravenous heparin with therapeutic doses. She was medically optimized with higher doses of statins and beta blockers, and managed pretty well. And then we converted her to rivaroxaban in a therapeutic dose. And we had to make a judgment to reduce one of the antiplatelets, so we took the aspirin off, and we continued Plavix, and she went home on a therapeutic dose of rivaroxaban and Plavix, with pain at minimal exertion, and we kept in contact with her every couple of days. And just yesterday, or 2 days before, the colleague contacted me that the patient underwent the surgery after she got tested negative, and now she has a definitive treatment, and she had a successful bypass surgery done.
So I think that reflects. I mean, this is a very controversial thing, and I think that case reflects the decision making of all of us as a group. And I think that is what's important for us in this case to really involve everyone. But there's one question for Dr. Olin that I'll email you, Jeff, because I don't think we have time to talk about it, but I will definitely email you. But I want to thank, Dr. Mako, who had to step out. He had something going on. But Dr. Ferries, Dr. Luxstein, Dr. Kapoor, Dr. Farhan, and Dr. Olin, of course. And, this has been incredible. We at last count, we had over 500 people, 600 people actually log in. I'm actually trying to get the latest data so I can tell you. And I think this has been incredibly effective. And most of these questions are from medical colleagues who are out in the field and really taking care of these patients. So on behalf of all of us at Mount Sinai, we thank our audience for the interest and for the care in taking care of your patients that you actually signed in during this difficult time. To our faculty, I know you guys, especially as leaders, are so incredibly busy. Thank you so much for taking time and spending this hour with us and sharing your insights. We all realize that there are no definitive answers, but with a panel of experts like all of you, I think it's incredible to allow for guidance for our doctors in the community to be able to at least have a discussion with their patients. So again, thank you. The CCC live cases and the peripheral interventions will continue next month. So we will sign on next month and we will see you. So thank you again, and be safe and be healthy during this pandemic. Thank you, everyone.
Thank you.
Thanks for organizing. Stay safe.
Take care.